liver, arm for locomotion, and the failure of this muscle tendon junction leads to a painful flat foot. So what is an adult acquired flat foot? Mind you that arch height is variable in a population. Like we have like a 6-foot gentleman as well as a 5-foot gentleman. Both are not abnormal. Neither one is a giant nor is a dwarf. But it's a variation in height. And a low arch is not pathologic. And there is a wide individual variation. So flat foot should be referred as an abnormal loss of arch with pain. So whenever a patient has a planovalgus foot with pain, that's when we kind of investigate it as an adult acquired flat foot. So flat foot describes as the end point of a collapsed medial arch with associated deformities in the hind foot and the forefoot. So the deformity is a three-dimensional deformity. The hind foot progresses into valgus, the forefoot compensatory supinates. In the sagittal plane, the longitudinal arch collapses with subluxation of the talonavicular joint or navicular cuneiform, the first metatarsal joints, combination of these. In the axial plane, the forefoot abducts or abducts as we all call it through the talonavicular joint, and in the coronal plane the heel goes in valgus. So this three-dimensional deformity, if you kind of get a picture of this in your mind, it will be easy for you all to kind of reverse this deformity or plan its management accordingly. So what is the etiology? You should kind of differentiate whether an adolescent comes or an adult comes, whether it is flexible or whether it is rigid, whether it is painless, like most young people who come to us, parents get them, or whether it is painful with certain coalitions or neurogenic or certain like inflammatory disorders. So most common adult etiology is tibialis posterior tendon dysfunction. Along with that, you may get an Achilles contracture, you may get inflammatory arthritis, you may get malunions of calcaneum, peroneal muscle spasms and neuromuscular disease, or you may get certain neuropathic deformities. All of this is kind of aggravated, or the end spectrum comes because gravity and weight bearing forces encourages destabilization. We are humans, we stand on 2 feet. The gravity is what progresses the deformity along with this. So what history do you need to ask? Like, patient comes, what is the reason for the visit? Whether it is pain, deformity, or some elderly in the family who just insistence that the foot is looking flat and get them over. Whether it is painful, what is the location of the pain? The onset of the deformity is right from when they noticed it from birth, or whether it has come in the last few years and how it has gone, how it has progressed. In family, just check the mothers or family parents or the parents' feet if they have any prior treatment or prior surgeries done for it. Where will the pain come from? Primarily the inflammation in the posterior tibial tendon and the superficial deltoid fibers which get stretched. As the disease progresses, there might be impingement on the lateral side, especially the talocalcaneal or lateral to the talus. But the calcaneofibular joint might impinge the distal end of fibula, and the calcaneal, the peroneal tendons can get impinged. As the disease progresses to stage 3 and 4, there is arthritis of the subtalar and the other associated joints along with it that might cause pain. In examination, check for laxities, ligamentous laxities, people are more prone for it. Check from the hip, knee, check for the genu valgum, what very commonly seen with them. Do a neurologic examination just to check the tone of the muscles. Check the foot whether the Achilles tendon is flexible to the Silver-Scrolls test. Check the callosity pattern. Check the subtalar motion, whether he is free, supple on the subtalar. Arch is restored with the toe raising, and also examine whether there is a point tenderness at certain areas like the navicular tuberosity or subtalar joints in an inflammatory pathology. Check the feet from behind, right from knee downwards. Observe the knee alignment or observe the heel alignment. See how things go. Inspect and palpate the tibialis posterior tendon right up to the muscle tendon junction. Ask the patient to do a single leg heel raise. When a patient does a single leg heel raise, if the tibialis posterior tendon is functional, the heel will invert, and that's what locks the midfoot and makes the foot into a complete lever, so that the locomotion is easier. Just imagine if you have to open a door at the edge of the door, the handle is there, it's much more easier because it has a longer lever around the hinge to open. If the tibialis posterior is dysfunctional, the arch collapses and you have only the midfoot and the forefoot to lever your body weight. It's like putting the handle in the middle of the door. You need more forces and more ergonomic generation of force to kind of locomote. So that kind of destabilizes and progresses the deformity. Check the gastrosoleus for tightness and check for subtalar motion tightness. How do you start the imaging? You need weight-bearing X-ray, especially apilateral oblique. This is a Saltzman view, which is like an axial taken of the calcaneum, but slightly more focus from the distal tibia downwards, and you can check how much destabilization or how much lateral is there. CT scans for correlations and MRI for certain neurologic reasons. So this is how it's taken in a Saltzman view. In a lateral is also taken lateral, so that you can check where the collapse is happening, whether it's happening at the talonavicular joint or navicular cuneiform joint or TMT joint. So tibialis posterior tendon dysfunction is classified in 4 stages. Stage 1 is where only the tenosynovitis, there is pain, swelling, no deformity. Treatment is very simple, arch supports, and kind of sometimes if it doesn't settle down in an inflammatory pathology, you can do a debridement of posterior tibial tendon. Stage 2 is where there are, when you check from behind, there is too many toes sign. It's a flexible deformity, means the patient is able to go on his toe raise but cannot stand for more than say like a 15 or 20 seconds. You start with them with arch supports, orthotics. You can do certain surgical procedures that we'll be discussing ahead. In stage 3, where there is subtalar arthritis, where the deformity is rigid, you need kind of orthosis in like orthotics in kind of a salvage procedure in like a palliative treatment, or you need to do a fusion in selective, whether which joint is involved. In stage 4, where the deformity is progressed from subtalar and the ankle is also involved, you need a salvage pantalar fusion, or you can combine it with a subtalar corrective fusion and a total ankle arthroplasty. So surgical options in stage 1, 3 and 4 are easier decisions. Stage 1, no deformity, is primarily conservative, and you can also do like debridement in resistant cases. Stage 3 and 4, it's a rigid deformity, arthritic pain, you need fusions. Stage 2 is where there are a lot of options, where your decision making comes into action, where you need to kind of really wear your thinking cap really hard and like think about it. How do you plan it? Which is the dominant plane of deformity? You need to check whether it's happening in the axial plane, coronal plane, sagittal plane. Check for the flexibility of the foot, hind foot, whether the subtalar joint is supple. Check for the medial ray stability, because you may correct the hind foot, but if the medial ray is still flexible or hyper flexible, your foot will again go in kind of a collapse and the patient will not have a satisfactory result. So coming to treatment stage wise, stage 1, where it's due to medial arch collapse and primary irritation, arch supports. Nowadays we do it customized, we have it over here, a lot of centers around the city have it. Along with that, you need to add some physical therapy where you do actually stretches, start activating the foot intrinsics, start working on the tibialis posterior inversion so that they kind of develop over a period of time. They develop a proprioceptive feedback. While walking, they can activate the intrinsics and inverters and maintain their arch dynamically. So treatment with shoe inserts, you have to always tell them that it's not going to alter the eventual shape of the foot, but it's going to give them functional, painless mobility. It's more of a functional insert than kind of a structural insert. So stage 1, open debridement or an arthroscopic debridement of tibialis posterior tendon. We do it arthroscopic over here. How do we do it? It's a supine position. This is the position of the foot. Kind of take a portal. First distal portal is my viewing portal. Proximal portal is my working portal. Under vision, this is taken. This is how it's done. You see the tendon. You see a small split sometimes. That area of the split needs to be repaired. We can do it arthroscopic with a running suture, with a running lasso, or you can do a small mini open at the site of tear and repair the tibialis posterior tendon. Very satisfying results when you select the patient appropriately. Stage 2 is where I was discussing, you need to kind of discuss it really well or like think about it. You need to first check whether the hind foot is reduced or not. Stage 2 hind foot is supple, it will be reduced. Along with that, whether the forefoot is abducted or forefoot is normal. When the forefoot is reduced, and again the next 2 sections are whether the medial column is stable or medial column is unstable. If the hind foot is reduced, forefoot is not abducted, medial column is stable, you need an FDL transfer for tibialis posterior augmentation. You slide the calcaneum medially and you need to get a spring ligament repair. When the medial column is unstable, because the first ray is unstable, there is a small amount of arthritis at the medial column, you need to add these procedures with a TMTJ fusion. That's the medial first ray fusion. That's what is going to give you a stable, a satisfactory result. In hind foot reduced, forefoot abducted, you need to add a lateral column lengthening. The same procedure as the last slide, but add a lateral column lengthening because you need to correct the forefoot abduction and bring that or swipe that to plantigate position. So its foot is not a joint, it's a 3-dimensional deformity in flat foot. There is a valgus hind foot, there is an equinus at the ankle, and there is a supination of forefoot. So normal, this goes, the right side what you see is the flat-footed pathology where the tibialis posterior is lost, the Achilles is tight, and the forefoot is subluxed. So how do you go about correction? You need to correct the valgus. You need to get these slides in your mind, and you will kind of, this is a line diagram where you will kind of reproduce this even in your exams. So equinus at the ankle is corrected by Achilles lengthening, midline incision, kind of isolate the sural nerve, resect and release the muscular tendon junction, midline rapid, feeler give way, close. This is how it goes. For the valgus of the hindfoot, you need to do a medial calcaneal displacement osteotomy, short lateral incision under C-arm, isolate again the sural nerve, subperiosteal dissection, osteotomize, translate, fix, close. So you see a translation of medial calcaneal. What does this do is, like, Achilles tendon is a very strong tendon. Since it is in valgus, it is everted. It also acts not just like a plantar flexor, but it also acts like an everter. So you need to change the force of Achilles from an everter and plantar flexor into a plain plantar flexor. That actually helps a lot in kind of getting the results better. So valgus of the hindfoot, FDL transfer to tibialis posterior, posteromedial incision, dissect, isolate the tib post and FDL, confirm that it is the FDL, debride the tib post, augment the FDL into the navicular tuberosity. So this is how it kind of, this is the FDL tendon on the right, and kind of get it back. Before fixing it, if you're planning to repair the spring ligament, isolate the undersurface of the navicular, repair the rents or reef in a stretched ligament. This is how it goes. Forefoot supination, you need a medial cuneiform dorsiflexion osteotomy. Extend the same incision distally. Dorsal opening wedge osteotomy of the medial cuneiform. You have wedge plates or graft from an iliac crest or allograft is easily available nowadays, and fix it. So symptomatic flat foot, equinus of the ankle, Achilles lengthening, hindfoot valgus, do a medial calcaneal osteotomy, FDL to tibialis augmentation and spring ligament repair. Forefoot supination into cuneiform osteotomy. So get this slide in your mind, and like you'll understand what the pathology is for the symptomatic flat foot and get that on. Stage 3 and 4, fusions with joint to fuse, do an MRI, do a SPECT CT, fuse the joints, patients are very happy about it. Stage 4, where there is ankle involvement, in our country right now I'm doing the hindfoot nail, but these are options which are available in the West, where do a corrective subtalar fusion and an total ankle prosthesis. So post-operatively, patient was not able to walk or do a single leg heel raise. Now we have an option where she is able to walk on her tiptoes also, and it gives very satisfying results. So take home would be, identify the etiology, take proper history, detailed clinical examination, justify your treatment. Don't cover our ignorance with reassurance. Our support should be customized. Surgery when indicated will always give a good results. So given the morbidity associated with arthrodesis of the joints involved in flat foot, we believe that patient should be surgically treated before progression to arthritis, and flat foot is an excellent option in management which can improve the quality of life of our patients. Thank you.